We have three levels of healthcare in Nigeria currently. We have the tertiary level, we have the secondary level, and then you have the primary level. What is happening is that the primary level is supposed to provide the basic health care. And because we have up to about 30,000 primary healthcare systems, it was set up in such a way that that 30,000, if all of them are functional, should be able to provide comprehensive or primary basic health care to majority of the population. But what is the current situation? We probably would not be talking about poor health indices in Nigeria if we have up to 60% of the primary health care functioning optimally. When I mean optimally, having the right human resource for health, having commodities and medicines, at least the basic ones, always available, and then also having the basic infrastructure in place. But because of the failure of the primary healthcare system in Nigeria, what you see is an overburden, both in the other level of care and the private sector. Now, I don't see any reason why a tertiary institution, a teaching hospital, should be treating uncomplicated malaria. It's not what it's set out to do. I don't see any reason why a tertiary institution should be treating common cold. That is not what it's set to do. But unfortunately, that's what happens now. The private sector is also overburdened because of the failure of the primary healthcare system. Now, when you're talking about the private health sector, studies have shown that currently about 60% of the population access health services through the private sector. The same private sector that we all say are poorly regulated, the same private sector that we are all saying have issues with quality of care, the same private sector that we are saying charge fee for services. We have about 60% of the population accessing care. What does that mean? It means that we need to begin to focus our attention to what happens in the private sector. Now, let me digress a bit. Because of the issues associated with the private sector, what you have found in the last couple of years is that a lot of upscale private hospitals have sprung up in virtually all parts of Nigeria. Good as it sounds and good as it looks, what we are doing is simply listening to those who have been making a lot of noise. And they are just about 30%. What about those 70% whose voices are not heard? Have you ever thought of a woman in Anka in Zamfara state? Where does she get her health care? Somebody in Enugu Agidi, I don't know those from Anambra here. How many of them, where do they get their health care? A woman living in Ogun Waterside, where does she get her health care? These are some of the conversations that we need to begin to discuss. I was talking to Vivian, Nigeria Health World, that I think one of the things that will be important to be done going forward is to begin to also have this conversation with the patients. Let's get them in a room and listen to them. We have been listening to ourselves long enough and we're not moving the dial. Nothing is changing. This time around, it's important we begin to listen to those people that we are providing care to. For somebody in Zamfara, providing quality care might not necessarily mean building fantastic hospital. It might just be the way he or she is being treated at the primary health care center. So we need to begin to have that conversation with the patient. And for me, I think that's what will make all the difference. And there are huge opportunities when you talk about engaging the private sector. They are trainable. They are always available. They are all over the place, particularly the patent and proprietary medicine vendors. Statistics vary depending on the source that you have, between 100,000 and 200,000. But I tell you, from evidence of several studies done, in 2015, the FP Watch actually shows that about 76% of the population access family planning services and commodities from the PPMV. And if you look at malaria, it goes up to almost 80%. And what are we saying? They are available there, they can be trained, they can be properly monitored, they can be properly regulated to provide a wider range of health services. Now, what needs to be done? We are saying that we need to begin to recognize the private sector contribution into our health system. As we speak, the Strategic Health Development Plan does not acknowledge the contribution of the private sector, particularly the community pharmacists and the PPMVs. And they are doing quite a lot. As we speak, what you find are commissioners of health, who are basically commissioners of the public sector. Nothing is happening at the private sector. Most of them don't even know what is going on in the private sector. Yet they're supposed to be commissioners of the state. So we need to begin to change the narrative. How do we look at health as a country? And there's a lot of data coming from the private sector. I was in a meeting. Some people were saying that the private sector hardly reports, except if you motivate them. The truth of the matter from our studies is that the private sector would give you data if you understand what you're using the data for. If you tell, for instance, a PPMV that if he keeps the data of, let's say, the number of people that he provides anti-malaria over a period of time, that it can help him even in his stocking practices, why would he keep that data? But oftentimes we don't look at that. The only data, national data we have is when we do surveys. But the routine data is only for the public sector. What is happening in the private sector? So we need to begin to change the narrative. And then again, we also need to look at how do we even create an effective referral system. A lot of us have been saying, yes, the PPMV, they go overboard, do what they are trained to do and what they are not trained to do. The truth of the matter is that if we create that enabling environment where they can refer, a lot of them are willing to refer. And that is what we have found out. And then, another very key thing is that the assumption has always been that the PPMVs are all the same. But that's not true. A study we did, PPMV landscape study we did in 2016, actually shows that up to about 38.5% of those who are practicing as PPMV have one health training or the other. And when you move up north, it even increases. And it's a huge opportunity for the country. Why can't you identify them and provide them the requisite kind of training that will enable them to provide quality health services to the people that they serve in their community? So we need to look at that too. And then we need to continue to monitor and supervise their activity. For us in Society for Family Health, we look at care from the point of providing innovative solutions that will allow a huge number of people access care, rather than setting up structures that will benefit just very few. And that's also the reason why we are currently implementing a project called the IntegrateE Project, which is a proof of concept that community pharmacists and patent and proprietary medicine vendors have the capacity to provide a wider range of, first of all, family planning and then primary health care services than they are authorized to do. And in doing that, we are supporting PCN roll out the PPMV tiered accreditation system, which is designed with patient-centeredness in view. I will give you an example. Some years ago, when we were training PPMV, because according to PCN's definition of PPMV as we speak, the PPMV from PCN's definition is those who have ability to read and write. That is the current way to define PPMVs. But there are more than that. There are some of them who are retired CHUs, some of them who are nurses. These are nurses that in some PHCs in the north, they had a whole PHC. And then when they retire and open a PPMV, they can no longer treat malaria or things that they were doing while they were in service. So we need to identify them using the PCN tiered accreditation system, which the project is piloting in Lagos and Kaduna State. When you identify them, it helps you provide the kind of training that they require. I'll give you another example. Many years ago, when we were trying to train the PPMVs, we got about 25 PPMVs in a room, and we are providing training on oral pills refill, and then balance counseling and referral. And when we did a pre-test in the same class of 25, we found somebody scoring as low as 20% and another person scoring as high as 70% in a pre-test. Now, tell me, as a trainer, how will you categorize? It's very obvious you're not talking to the same people. But what most of us are doing is just to check. We have trained. How many people? How many have you trained? 200. But what is the training translating to? And that is what is important if we are looking at patient-centered healthcare. So if we are building the capacity of the PPMVs at the lowest level to be able to provide care, then we should be able to properly identify and stratify them. And that's what the PPMV tiered accreditation will help us do. And beyond that, too, one of the problems that working with the PPMV raises the concern about supervision. And the project is also trying to pilot what PCN mentioned, the hub and spoke model that allows a community pharmacist or a pharmacist to be able to supervise a number of PPMVs within a cluster. That, again, is a way of guaranteeing the quality of services and the quality of drugs that this PPMV stock. And now, too, finally, the project is also mapping PPMVs and community pharmacies around PHCs for referral purposes. So they are actually willing to make this referral if the system is established. And then again, we are also trying to integrate the data using family planning, as an inroad to integrate the reporting data from the PPMVs into the national system. And now quite a lot of them are providing those services and they are being captured. What am I saying? I am saying that we need to shift the conversation. We have been talking to ourselves for too long. What we have been doing is just providing care for a very few number of people because they are the ones demanding, because they are the ones speaking. Just like Usie said, they are not here talking to us. Some of us are speaking on their behalf. But we need to also begin to listen to them. They are not talking, not because they don't want to talk. They probably don't have the platform to talk. So we need to consider that in all that we are doing, knowing fully well that they're actually the one reaching the last mile. They're actually the one providing these services to people in the communities, people who need these services. And that is what will redefine patient-centered healthcare going forward. Thank you very much.